Much as Noam did, we are going to go through some cases to try to elucidate kind of a pathway or approach, and this will be kind of a give and take, so to speak, with each of you. Kind of informal, and we'll try to come up with some, what do you do in the real world? So this first case, 63-year-old gentleman with a history of adenocarcinoma of the prostate, presented in 2013, had a Gleason 4+3 prostate cancer. Initial PSA was 9.3. He had a prostatectomy and his T3N0, and you can see the clinical information. He was then lost to follow-up, and 5 years later, he had extensive high-volume multifocal bone metastases on his bone scan with 3 small liver lesions on CT. His PSA was now 176. Since he had last been seen, he had previous MI and had cardiac stent. His BMI is 40. He drinks 4 to 5 spirits a week, doesn't smoke. So I'm going to ask some questions here. So first, to our medical oncologist, how do you approach from a hormonal option now? You saw some of the data that Dan presented. In addition to that, how do you select out who gets chemotherapy, who doesn't? And which hormonal agent do you use?
Yeah, so this is I'll go first, I guess. So this is very similar to the presentation I gave in the case I presented. This is not a de novo case, but essentially, patient has extensive mets and was lost to follow up for 5 years. So biologically, could argue that this could be a de novo case. One note, liver mets a little bit unusual in prostate cases. Certainly can be see about 10% of the time. I like to often biopsy liver mets in prostate cancer to make sure they don't have small cell. This is on a side note there, because their treatment would be different with chemotherapy. But if this is adenocarcinoma, which is, it could certainly be, those patients need to be approached with hormonal therapy, androgen deprivation therapy, and obviously the question is going to come into play that, like I just presented, should this patient get a triplet or a doublet? So really the comorbidities is the main defining factor here. We'd have to look at his ejection fraction and his fluid overload issues as relates to abiraterone and prednisone. Those are the major concern. Well, fluid overload, those are often relative concerns, but I would look into that. There's some data on cardiac toxicity with the AR inhibitors, but again, if he had a stent and if he's right now doesn't have any angina, doesn't have any ongoing ischemia, that shouldn't be a problem either. I would probably lean in a patient like this, as you're describing, probably towards ADT plus enzalutamide. But again, if it's cardiac optimized, you could consider a triplet. But probably I would shy away from a triplet given his comorbidities here.
Brian.
So, yeah, I'm a believer in the triplet data. I was a believer after PEACE-1. I'm even more of a believer after ARASENS. I think what would drive me is his high volume disease, so we don't have the high volume, low volume question, and certainly the visceral mets. Now, his ability to tolerate it, it's hard to tell from text on his screen and sort of would he pass the eyeball test, but I think, 68, I would consider that young, and I would try to give him triplet therapy, at least try to start down that road. What regimen would I give him? Well, I'd love to give him, darolutamide, because I think it's the best tolerated. It's not approved in that setting yet, so putting the reimbursement issues aside, but that's what I would do.
Have you had reimbursement issues with darolutamide?
Well, I haven't tried it in this setting because the data just came out last week, so.
But even so, it's really only in the non-metastatic setting currently.
Correct. Yeah, correct.
But have you ever?
I've not tried it in this setting, so I guess, I think Abby would be a good choice with the fluid issues that Dan mentioned.
Okay, so along those lines, so you're specifically selecting out the higher volume disease for the triplet therapy. Is that what you're?
Well, I don't, the ARASENS did not present volume data. You've made it easy by just saying that he has extensive high volume, but I think if he had low volume but liver mets, it would make it much more challenging. I think we'll see the ARASENS volume data at some point, maybe ESMO. All the data would suggest that chemotherapy is really only helpful in high volume disease, right? Charted and all the other data. So I think without high volume, I would not give chemotherapy.
Okay, great, thank you. Okay, so obviously, if you were not going to use chemotherapy, you have a multitude of different novel anti-androgen therapies to select from. Are any of them better than the other? How do you select those things out?
Again, I mean, I have to look at the comorbidities for abiraterone. I'd be concerned about possible volume overload, so I'd like to know what his ejection fraction is. I'd like to, see the patient edema and things like that. And then apalutamide, I've had a lot of issues with hypertension with apalutamide, and I tend to shy away from that for my patients with cardiac risk factors. So I typically tend to use enzalutamide in a patient like this if I'm going to combine.
So it's not an efficacy issue, it's more of a
Comorbidities,
comorbidity.
right.
Okay. Heather, on that front, how do you describe the differences in terms of ADT-related side effects and how you kind of manage those things?
Well, in the interest of time, especially since we're what's keeping people from lunch, I did go ahead and put together a slide because it's a lot to cover in a short period of time. But I think we're all pretty familiar with the general toxicities we see with ADT, and I put those in the green there on the left. And as Dr. Vaena kind of already alluded to, it's not necessarily an efficacy issue. It's really trying to play a matching game between what comorbidities your patients bring to the table. And in the greater Mid-South region, I think the patient that you presented is pretty typical of what we're seeing. In fact, it's actually probably better than what we're seeing because he doesn't smoke. Probably most of our patients are coming to us with a cardiovascular history. They're coming with diabetes, probably poorly controlled at that. And whichever agent that you choose, I think for that patient in particular, you need to pick up the phone and make sure you're connecting with their cardiologist or their cardio-oncologist and really getting an understanding of what their cardiovascular history is so that we can make sure whatever drug that we pick for them, they can be the most successful going forward. I think one of the things too is that I've seen a couple of times is that if we're not specifically asking about a past medical history of seizures, if they don't have a seizure disorder or aren't on an anti-seizure medication and maybe just had a random seizure in 1972, that can get lost on the medical records. I think we need to be specifically asking that question for these patients too.
Great. Okay, now, we'll get to the HR mutation issue in a second, but are you guys ordering molecular testing up front, or are you waiting for them to be castrate resistant? How are you approaching that?
Yeah, I struggle with this a little bit. I think in a patient like this with aggressive disease, I would probably biopsy a liver lesion and send it for testing. If somebody has a more indolent feel, I might wait because their disease may change over time. Okay. But I order early-ish, but not necessarily on day one in everybody. Okay, and we'll get to a little more about difference between tissue and liquid.
And just to make a point, there are ongoing trials looking at intensifying with PARP inhibitors even up front now. So if the patient is able to travel, it could be interested in those trials. There is a role for knowing if they have BRCA mutations up front now.
Okay. Okay, so this patient started enzalutamide and leuprolide by his urologist, and he was placed on denosumab. His PSA dropped to 4, his pain was essentially gone, and he remained asymptomatic. In April of 2021, his PSA rose to 5.3 and then 5.8, and his imaging had shown a response, but there was some residual bone metastases present. So what are his options now at this point? And what's the best option for him?
So I'll guess I'll go ahead and start. So basically, he's now castrate resistant, and he's already had enzalutamide. So the first thing that I do in the situation, I make sure that they're truly castrate, get a testosterone level. Rarely you'll see patients who are not castrate for whatever reason, the last leuprone didn't take or whatever. But again, expected to be castrate resistant. And then typically, I would offer chemotherapy in this situation. Get restaging imaging, ensure that the patient, is defined now as metastatic castrate-resistant, and consider chemotherapy. Again, if this rise from a PSA to 4, 5.3, 5.8, I'd probably wait a few more weeks to make sure it's truly going up. But if it is, chemotherapy would be my next recommendation, probably with docetaxel. There's,
before second line.
Right. So the common consideration, and patients often prefer to be switched to another oral drug, in this case would probably be abiraterone, you could get an ARV7, the splice variant, to see if there's a splice variant, just to exclude the presence of a splice variant to make that decision. But that being said, the data that we have from a later trial that was done in patients who had docetaxel before, and then we're contemplating should they move on to cabazitaxel or to another AR inhibitor. So they had prior AR inhibitor, they had prior docetaxel, and the question was, do you move on to another AR inhibitor or to cabazitaxel? And the data was better with cabazitaxel, suggesting that moving on to second AR inhibitor doesn't do very much, or abiraterone wouldn't do very much. So I think it's a little bit an extrapolation from that second chemotherapy type of question, but generally speaking, from an overall survival standpoint, I prefer to switch them to chemo at this point and not to abiraterone, and I typically will save abiraterone for later or last resort.
Okay. Brian, what do you think? There's obviously a lot of potential options here.
Yeah, if he's asymptomatic with stable imaging and just a minor PSA rise, the first thing I would do is nothing. I would just watch him for as long as possible. There's not curative therapy for him, and so I think I would just wait until either a more definitive PSA rise symptoms, and or imaging changes, but assuming that happens. I would probably tend to give him Abi and not go straight to chemo. I find most men don't want to go to chemo, again, putting trials aside. This would be the point at which if I didn't have genomic information, I would get it or rebiopsy and get it for the, PARP inhibitor discussion.
Do you test ARV7?
I don't routinely. Yeah, I don't routinely.
Okay. And then in terms of now checking for HR mutation or checking molecular profiling, you use tissue or liquid? If so, how do you check liquid? Do you check germline testing? Obviously, there's a lot of ways of
institutionally, we have a contract with Tempus, so we send tissue out, and then they send blood as well, just sort of as I don't know if it's a backup, but obviously I would base it on tissue if it produces results.
Is liquid as good if you identify a HR mutation?
I think so. I don't know the data. I don't know if there's comparative data, but it's not as sensitive, of course, but I think if you find it, it's real. I don't know that there's specificity issues.
Yeah, okay. Certainly some of them, Propel obviously enabled liquid as a entry into the trial.
Right.
So I assume more and more trials are now enabling liquid.
Now, the important thing would be not only if you're going to do somatic, you do either tissue or liquid, that's one point, but you also should do germline separate from that. So don't forget to do the germline as well.
Okay, great. So this gentleman received apalutamide, Sipuleucel T, radium-223 in his urologist's office. He has a somatic BRCA2 mutation. AR is mutated, and there is TP53 mutation on molecular profiling and no germline mutations. He then started on olaparib. PSA went down and remained down. He had progressive anemia requiring occasional transfusions, and his imaging showed no progression. PSA is rising. So Heather, what do you have to look for with PARP inhibitors, and what should you be concerned about? How do patients tolerate this?
I think in general, two major categories, hematologic toxicities and GI toxicities. And obviously most of that data is with the breast cancer patients. With both of those toxicities, best are managed with dose reductions, delays, interruptions. But one thing to keep in mind that we saw with the breast cancer patients is there is a risk for myelodysplastic syndrome or AML. So if a lot of these prostate cancer patients already present with cytopenia, so if they're not improving, or certainly if they're getting worse despite your best effort, make sure you're thinking of maybe keeping that in your differential and doing a bone marrow biopsy. And then pneumonitis can also be an issue. So if your patients are coming with cough or shortness of breath, chest pain, keep that in your differential as well. But I think in general, they're well tolerated and easy to manage. Okay, great.
All right, in the interest of time, we'll move on to the next case. So this is a 69, shifting to bladder we'll ask a couple questions on this. 69-year-old smoker, 3 weeks of gross hematuria. He has a thickened bladder wall, mild moderate right hydronephrosis. He went to a urologist, and there was a non-obstructing fungating masses in multiple sites in the mucosa of the bladder. He had a TURBT done, was found to have high-grade muscle invasive urothelial carcinoma, somewhat resistance to undergo surgery. he smokes, and his GFR is 47. So the question is, what would your approach to neoadjuvant chemotherapy be, and what are his options, and how do you approach this? Brian?
I mean, I think my approach to neoadjuvant chemo would be not to give it to him. You have to use cisplatin. I generally don't give it under a GFR of 50, and this guy doesn't sound otherwise healthy, so I think
pretty close.
What's that?
He's pretty close to 50.
Yeah, he's not close enough. So I suppose you could recalculate it and hydrate him, and you can sort of do that. But 50 plus, I'm pretty comfortable. As it gets into the 40s, I'm much less comfortable on it. So I would, again, that caveat aside, we'll probably just talk to him about going straight to surgery, or we could talk about chemo RT as an option. But he has multifocal, and so I'm not sure he's the best candidate for that.
Right. Dan?
So I've used the neoadjuvant split dose cisgem approach in patients like this. So my cutoff is a little bit lower than that if I use split gem. So split the cisplatin on day 1 and 8, 35 milligram square on day 1, 35 milligram day 8. And I haven't seen that much toxicity with that in a patient like this. So I tend to go down to GFR 45 or 40 if I'm going to split. Again, depends on his overall comorbidities, but that is something that I would consider. Yeah.
Okay. Was it anybody impressed with the enfortumab vedotin data presented at GUASCO, or a little too early, a little too toxic?
I think too early, yeah.
Yeah.
Too early, possible a couple deaths that were.
I mean, there was promising data with the PCR rate. I think was about 35% phase 2 setting, but there were some DVTs that were seen post-op. Hard to know if those DVTs were just because people get DVTs anyway after surgery or not. It's the first time that I've seen the data, at least, so I think it's early, but definitely there's a lot of emerging data out there with immunotherapy, chemoimmunotherapy, and just like you said, ADCs in the neoadjuvant space as well. So I think we definitely have to watch this very closely the next few years. And it would certainly apply for a patient like this in the next few years, probably.
Okay, so getting back a little bit to trimodality therapy, how do you select out who's the best optimal? Holger, how do you select out who the best candidates for trimodality therapy are?
Well, a lot is also patient preference here, but if you have patients that have a functioning bladder to begin with, and that's kind of key, because if you have a non-functioning bladder, you don't preserve anything there. And if you have functioning bladder to begin with and can have complete TURBT, those patients are actually good candidates for chemoradiotherapy. Interestingly, even in patients that have multifocal disease, where you cannot spare parts of the bladder and have to treat the entire bladder with radiation, you actually end up with decent bladder function afterwards. I usually tell my patients that the chance of having a functional bladder is about 70% after chemoradiation. So that's actually a pretty decent number. Also, studies have shown that if it doesn't work and it fails, patients still can have a salvage cystectomy. So you really don't lose a lot by trying this approach.
Yeah, so I mean, trimodality therapy is essentially re-TURBT with chemoradiation, just for the...
Well, TURBT is only important if the first TURBT was a long time ago and a complete TURBT was not done for some reason or could not be done. Otherwise, if it's done, then you just move on.
Okay. All right. Anybody have anything else to say about that? No? Okay. So, and then what is the current role for circulating tumor DNA in these patients? They're not really a role. It's really investigational at this point, but is anybody... I mean, is that of interest? Kind of. I mean, is that where?
Of interest, but we're not using it clinically yet. Yeah.
Okay. Okay. So this patient got neoadjuvant split dose gem-cis followed by radical cystic prostatectomy. There was residual T3N1 disease with 2 out of 12 pelvic nodes involved. Good tumor response seen. So the question is any adjuvant therapy in this setting?
I mean, I would certainly think about adjuvant nivolumab in this setting. I guess I'd be worried that he has residual nodal disease after chemo, so I don't know how the good tumor response was determined, but this patient's in trouble, right? If you have bulky nodal disease after chemo, this patient's in trouble. So we can talk about the adjuvant nivo data, but I would certainly consider it.
Yeah, agree. Agree?
Agree.
Yeah. Holger, what about adjuvant radiation?
Yeah, I would offer adjuvant radiotherapy, although the data is slim. This patient has no positive disease, T3 disease. Those are the indications to give adjuvant radiation afterwards. A lot of the data, and there's only a couple of randomized trials, and it's older trials that were done, came actually from Egypt. And in Egypt, of course, most of the bladder cancers are predominantly squamous cell carcinomas, whereas here in the United States, they're urothelial carcinomas. So we don't know really whether the data completely translates. But you can see an improvement in disease-free survival, not overall survival, unfortunately, but there is an effect on local recurrence. So I would offer this. Patients are limited, doses that we can deliver are limited due to small bowel toxicity because when you remove the bladder, the small bowel just falls into the pelvis and it's sitting there. So you can do IMRT and those things, but sometimes if you treat the bladder bed, you can also just do 3D.
Great. Okay, moving on to RCC. Last case, 72-year-old gentleman, history of atrial fibrillation, a bunch of medical issues, and had a CT that shows a very large right kidney mass that extends to involve Gerota's fascia, and there does appear to be a fat plane, and just above the iliac wing. There's diffuse nodular thickening of the Gerota's fascia laterally, no other sites of disease, no disease in the liver. So, Brian, how do you approach these kinds? Is there any role for neoadjuvant therapy in do you select neoadjuvant therapy in anybody? Is there any role off of a study?
There have been a bunch of neoadjuvant TKI trials over the last decade. It can definitely shrink tumors, but in this, shrinking it from 11 to 9 centimeters is not really going to matter, right? It's not going to affect this patient getting a radical. We will do it sparingly in patients, say, with tumor in a solitary kidney, bilateral renal masses, but it's a couple times a year, maybe.
Okay. And is there any emerging data coming out of some of these trials that you're aware of that look promising?
For neoadjuvant therapy?
For neoadjuvant.
Yeah, I mean, neoadjuvant is difficult in kidney. There aren't established endpoints like there are in bladder with complete, path CR rates, et cetera. So there was just data with axivalimab neoadjuvant presented at ASCO GU, and yeah, you can shrink tumors, you can probably see some cell changes, but it's not clear what the clinical effect is and if you're helping patients, or that there's some regulatory path to pursue. So I have a feeling it'll be a playground for biology, but not really clinically useful.
Great. Okay, so he ended up getting a radical nephrectomy that showed a 12.4 by 10.3 by 9 centimeter grade 4 clear cell carcinoma invading through Gerota's fascia. Margin was positive. So I assume that this is a patient that you'd be taking your Keynote 564 data and saying this would be an ideal candidate.
Yeah, I mean, presumably it's T3 because it's into the perinephric fat and high grade. So yeah, I think this patient probably has a 40-50% risk of recurrence. So barring contraindications, I would certainly talk about it.
Okay. Great. Dan, you agree?
Agree.
Yeah, you agree. And you already wonderfully articulated who are the patients that you would give to and who would not. You obviously are going to get some of these T3 and 0 patients that are probably a little lower risk. Do you actually calculate out risk of recurrence and then make your decision based off of that, or do you take what kind? I mean, you obviously the sarcomatoid and more aggressive, but how do you the ones that are a little more subtle?
I mean, there are online calculators. You can imagine there's 4 or 5 of them out there. Fox Chase just put out a newer one based on the ECOG adjuvant study. I don't tend to do that. I sort of tend to back of the envelope calculate it, and if they're up towards 40+%, then I might lean, might suggest it, a little more heavily, and if they're less than that, then I might be a little more cautious. I mean, you could still give it to a T2 high grade, right? They were eligible for the trial, but the absolute benefit's lower, and therefore benefit risk isn't as favorable.
Right. And Holger, what about adjuvant radiation and margin positive?
Yeah, in kidney cancer, that's we don't really have good indication for this. And when you look at the current NCCN guidelines, the radiation is really only mentioned in the setting of metastatic disease that you can treat, or maybe as an ablative method in a early stage renal cancer, but then we are in competition with partial nephrectomy and other ablative therapies. So it has not really panned out to be of great value, and unfortunately, we don't have much to offer in this setting.
Great. We have, okay, so actually an interesting question from the, we're going to move on to the last part of this case, but interesting question that came through. Is there any concern for patients who progress on adjuvant pembro to preclude them from benefiting from immunotherapies for metastatic disease when they develop?
Yes.
Yeah. So,
We have no idea, right? It's the big question is, and I think what I've heard so far, and I agree with, is if somebody progresses through adjuvant pembro, that's different than if they got it 5 years ago, which obviously isn't possible today.
Right.
But we don't know, and there are trials being designed in that setting. But you would imagine it would affect, but how exactly, we don't know.
although presumably if their cluster is designated as immune mediated, you'd expect that that's still the same mechanism now?
Yes.
Or is there breakthrough?
I just love that you're talking about clusters.
Well,
It's amazing.
I love I mean, I thought that was very interesting, but like, do you shift clusters over time? Is there,
We have no idea. All that data is one point in time, but there are some Mike Atkins presented an HCRN trial at ASCO GU, and they have sequential biopsies and will look at clusters so that, I'm sure biology changes over time. Do we have data that shows that? Not to my knowledge.
Okay.
No.
Excellent. Okay, so prior to initiating adjuvant therapy, he was having increasing pain in his ribs and back, and he comes back to clinic. His bone scan and a contrast-enhanced CT shows bone metastases in multiple ribs, right scapula, several vertebrae. There's also some soft tissue nodules subcutaneously in multiple locations, and several nodules in the renal bed, and 1.5 centimeter para-aortic node. So, Brian, you talked through so eloquently your frontline approach, and how would you approach this one? I mean, is there any unique factors around this case that would allow you to select one combination over the other?
I think the only thing is, rapid recurrence, right, in multifocal sites. And I can't remember, you said he's symptomatic. So I would almost certainly choose IO-TKI. I've tended to use len-pembro based on the highest response rates, although it's a more difficult regimen. So, sort of that eyeball test of fitness, do I think they can tolerate 20 milligrams of len?
Do you think that that obviously there was intentionally len went high at 20 milligrams, cabo went low at 40. Does that account for some of the higher response,
It could.
lower toxicity? In other words, you bring it all together,
Yep.
and let's say you give cabo 50 and len 18 or something like that. All of a sudden, you've got kind of similar.
Maybe. Yeah, we'll never know.
Yeah,
but there is a dose-effective TKI, so you could argue that the 40 milligrams of cabo in cabo-nivo underdosed a subset of patients, and so the response rate was 55, not 71.
Right.
Pure conjecture, but believable.
Okay. Okay, so, and then with all of this morass of data in the front line, what now? Where do we go in the second line now? It becomes pretty complicated.
Do you have time for me to give another talk? Real quick?
Yeah.
Is that? I mean, frontline's been great. There's all these data, but in the second line, has really not been much. It's single agent TKI, which is wildly unexciting. There's 2 trials of IO-TKI versus TKI in IO refractory that are ongoing that will answer that sequential immune therapy question, and then novel drugs and such. But for now, it's probably single agent TKI, which I think we would all agree is fairly unexciting.
Great. And then I think we're running out of time, but I'm going to ask a last question. Molecular classification outside of cluster in RCC. Standard molecular profiling. Is there any added value? Is that going to help us delineate going from an IMDC risk to a new molecularly enhanced risk criteria, or do you find any value in molecular profiling?
I don't. I rarely set it. I rarely send that testing. It's desperation in a young, healthy 3rd, 4th, 5th line patient where I'm just hoping against hope that there's some trial or some bizarre abnormality. I can think of maybe one patient in many years where I've actually acted on it. So it may change in the future as we get more drugs, but it just doesn't seem to be important in RCC.
Does it give you any kind of insight into what's driving the tumor one way or another?
Not to my knowledge.
Yeah. I agree with that. I usually don't think there's value either. The patients I tend to send are, again, the younger patients, more late line. If you're trying to find something, usually you don't. The patients, the cases I think are a little bit more helpful if you get the poorly differentiated carcinoma or the unclassifiable RCC that comes back with a VHL, then you know it's clear cell.
Or non-clear cell.
Right, or non-clear cell, right. So that could be helpful, especially if you have belzutifan coming up and all these things, you can consider that. And then the non-clear cells for papillary, looking for MAB mutations, things like that. But for the run-of-the-mill clear cell RCC, usually it's not helpful.
Okay, that's great. Any questions from the audience? Dr. Tower, wow.
The second patient, I think, that we heard about, is obviously taking care of. Oops, sorry.
Just want to make sure.
The second patient was treated by a urologist for a long time and used Provenge. Do you use any Provenge?
I do not. I think
Yeah.
there's very little effect.
I do not either.
Yeah.
And I think that's been sort of relegated
my
to the
urologists
urologists. Yeah, the urologists use it a lot. And I just wanted to make sure I hadn't missed something. I didn't think
You're
I
not
had.
missing anything,
But,
yeah.
Thanks.
What about PSMA radioligand? When's that?
Yeah, I'm ready. Like, we're on like a bunch of patients waiting. Yeah, like, I don't know what the PDUFA date is, but let's go. We're like that one I was going to mention in that one patient, that would be a great option.
Yeah, that would be.
Well, that patient already had radium-223, so I'm not sure if he has mainly bone disease. If
Yeah, fair enough.
177 lutetium is really going to help that much in that situation.
Holger, that is a great point. I mean, you're going to have a lot of those kinds of patients that have come from the urologist's office having already received radium-223.
I don't think we know that data yet, though.
No, but I don't know. It's
I mean, the interesting part is that radium and the older strontium that we used in the past, they basically follow the pathway of calcium. So if you have deposits of calcium or metastases, plastic metastases, basically that's where they go to, and that's why they used in bone metastasis. Where the exciting part of the radioligand treatment, PSMA radioligand treatment, is that it actually can also address other metastases because it's really attaching to the prostate-specific membrane antigen, and that can be anywhere, basically. So it is an advantage. The lutetium problem is that it's still a heavy beta emitter, so basically electrons, and compared to radium-223, which is basically a helium particle, alpha particle. The difference is that when you have like an electron, it's not as heavy and it doesn't go, it goes further. And for bone, for instance, it can cause more hematologic toxicity. The radium is an alpha emitter, so basically it doesn't go very far. It's a very heavy particle, about 10,000 times heavier than an electron. And you can even shield with the newspaper, but the short distance there it goes, it causes a lot of damage, and that's why it's so effective in this. And I think there's in the works also one that's coming out is going to be 225 actinium PSMA, and that was also an alpha emitter. So we're probably going to not stop at lutetium, which is really not approved yet, but if you have like $10,000 and want to go to Germany, the University of Bonn is offering it to anybody who wants to come and get it, you know. So, huh?
You go to Australia anywhere, I think that they have.
You can go there too. I mean, you can just have to go abroad right now. It's not really available here. But as you see, that's going to be
Hopefully it'll be
more useful.
available pretty soon. I think the anticipation is imminent. I guess the question is what exactly the indication is going to look like and what kind of imaging is required in order to administer it and how to get it out to, but clearly very effective.
Interesting with the imaging, besides being a kind of a moderately heavy beta emitter, it also emits 2 gamma spikes. So we can actually do a scintigram and actually see where the tracer goes.
Interesting.
I was going to ask a radiation question until you started using alpha and beta. I may have a revolt here, but for Dr. Gieschen, on that bladder cancer case where you had multifocal disease, does that influence whether you choose like a hypofractionated regimen versus the conventional fractionated regimen where you might be able to boost portions of the bladder?
No, that wouldn't make the difference. The difference would be if I had a lymph node positive disease, then you would have to cover a larger area that you might use a simultaneous integrated boost in treating the lymph nodes as well. For the bladder itself, there are two regimens, the one that goes to 64 gray at conventional doses at 2 gray per fraction, or the 55 gray in 20 fractions, which has been much more commonly used in the UK. And recently, they looked at a couple of their studies, the BC 2001 and the Beacon trials, and evaluated them. And there seemed to be actually some benefit to using the hypofractionated treatment. So if the small bowel plays nice and stays away, I usually try to use the hypofractionated treatment. It's only 4 weeks of treatment instead of a much longer treatment. Patients like it, and they tolerate it quite well. And I think the toxicities in the long run are the same whether you use the longer course or the shorter course.
Okay, thank you, everybody. Thank you so much for coming up and for the discussion. Very, very interesting discussion.